more lecture to go, na?
Yes, and I
That,
think uh, there was some confusion either to me or to some, because my talk was also given a fingertip and nail bed injury, and Dr. Agrawal has covered it so nicely. But then I remind one, I was talking to some IITian. He attended some memory class in Bangalore. He said, if some concept is repeated within 10 seconds of giving one concept, and then within hour the same concept has been repeated, then it goes in your mind permanently. So probably he has given all this thing. I will rush through that so that there will not be any harm, and this is the most common injury. I think you will all will get benefited out of it.
okay.
But definitely there will be something different. Extremely common and usually not adequately treated. That's why in 1967, Dr. Horal Kleinert wrote in an article that the deformed fingernail is a frequent result of failure to repair the nail bed injury. To know what is the nail bed, what are the component of the nail bed, how you should repair, you should know the fine anatomy of the nail bed. If you see that, the first you should understand the terminology. The nail is nechium, right? Epinechium. Above the nail is the skin is called as epinechium. Parallel to nail is a paranechium, and below the nail is a hyponechium. So terminology, paranechium, epinechium, hyponechium, you should know that. Now this is the nail plate. This is again not working. Yeah, this cornified tissue is a nail plate. It is a dead structure. It is the production of the nail bed germinal matrix. What is nail bed? Nail bed is the thing which vascular tissue which lie below the nail plate. It has a two component. Can I get another one? Yeah. This portion, the portion below the lunula, is a germinal matrix from where the nail grows. The cornified matrix, this plate goes from this. And this is adherent to sterile vascular matrix, which is called as a sterile matrix of the nail bed. So, this again, if you look at this, that's a epinechial fold, that's a germinal matrix, and that's a sterile matrix. And on there, the nail plate rests on it. How do you classify? I think it's a subungual hematoma. It can be simple nail bed laceration. It can be complex laceration. It can be the avulsion of the nail bed with associated fracture, and it can be a total dislocation of the nail bed. Like this, you have seen very common thing. The thing has gone black. It is a simple nail bed hematoma. There is severe pain because there is a pressure on the periosteum, and in the bone the periosteum is the most sensitive structure. If hematoma occupies more than 50% of the nail plate area, then it is ideally should be explored and repair the nail bed, which can be done in the local anesthesia. The pain gets relieved and the chances of getting the disfigured nail is much lesser. Simple laceration, the nail plate has been dislocated, not the nail bed. I am talking about the nail plate, the dead portion of the exposed dead portion has been, and simple repair. If you open it up and you see the nail bed has been transversely lacerated, you repair with the simple 6-0 chromic. This is how the diagrammatic representation is there, and you can get a very good result. There is nothing exciting about it. The only thing is you have to be vigilant to do that. Then here there is a fracture of the shaft of the distal phalanx with a nail plate has come out. There is a fracture, there is a gross laceration of the nail bed. You stabilize the fracture, you repair the nail bed, you repair the epinechial fold, you can have a very good cosmetic finger. You can come across a nail bed which has been dislocated in such a way that the nail bed along with the sterile matrix, which is this portion, has come out and resting on the epinechial fold. Leaving this is not going to generate the nail. If you find this, there is a dislocation of the nail, right? You put it back, by this pull-out suture technique and repose it, and you can see what the results are possible. It's just a simple surgery. Just you have to be vigilant and observant to do it. A child who was playing with a Chinese toy, the battery got burst, and this is the thumb which he has. There is a loss of the pulp tissue, there is a loss of the bone, plus there is a loss of nail bed. He is around 12-year-old child. Can we do something out of that? Yes, there is a possibility. You can first reconstruct the volar soft tissue, whatever is there. I think there is nothing. Volar is required to cover the flap. In a child with a vascular bed of the bone, you can take the split thickness nail bed graft from the great toe. You take the nail bed, you size the defect, you take out the nail bed graft split thickness with the help of a 11 number or 15 number knife blade, and then put it to the graft like this and wait for the result. Once the wound healed, he never came back. 3 years down the line, I took out my papers, took out at what date he was operated, then I made a phone call. Because of WhatsApp and free net available to Geo by everyone, they immediately send me the photo. Sir, this is my photo. A patient having that much loss of nail bed with that much, put a nail bed graft, and this is 3 years down the line. This is the donor, great toe donor, and this is the thumb. It's just simple nail bed grafting was done, nothing more than that. Sometimes ill treatment, improper reduction can cause a bony osteophyte. And this child was, when she came into the class 11, it was very difficult for her to write because they have to write continuously for 3-4 hours. The osteophyte was causing the problem. That is the osteophyte. So just simple excision of the osteophyte can solve the problem. Though now you can see the improperly treated nail bed injury as a disfigurement. What is the hook nail? It is because of lack of soft tissue support. That's why Dr. Pawan Agrawal has pointed out, the sterile matrix has to be taken 2 mm proximal to the bony support. Is that right, sir? Lack of bony support. If you don't have the bony support, the nail will grow without support and like this. So your the sterile matrix has to be 2 mm. The end of the sterile matrix has to be 2 mm proximal to the ear bone end. Linden osteotomy of distal fillings, which is called Argentina procedure. I have not done it. And Sudhir sir, if you have any experience of this, no experience, it is a book picture. We have covered the nail bed injury. Now I am coming to the overlapping part with Dr. Pawan Agrawal, but I will run through it quickly. Consideration should be given, as he has said, to age, sex, occupation of feather, and whether the bone and tendon are exposed or not. Then there are varieties of option available. Just epithelialization, revision amputation, spin graft, maybe full thickness, maybe partial thickness, flap coverage, replant of the amputated part, graft reposition over the flap, and composite tissue grafting. If bone is not exposed, that much of the finger, this photo I have borrowed from Dr. Prasoon Anand, on which India or the discussion was going on, and I was strongly for this finger in the favor of a conservative line of treatment. Then he sent the picture to me. That was the defect, and if you see on the lateral view, there is a good amount of pulp is there. Sorry, good amount of dorsal skin, and this healed completely just by doing the moist dressing. So if the bone and tendons is not exposed, the best line of treatment, even if the defect is large, is a conservative line of treatment, because the disfigurement is not there. You get a natural color, you get a natural fingerprints, plus the the mark of skin graft, that is the difference in color is not there. And the most important thing is that 2-point discrimination, sensation is normal in this type of patient. So given a choice, this is the best option if the bone and tendon is not. But how do you classify fingertip injury? Another way of classification. He has given one way of classification: fingertip injury if bone is exposed, transverse, dorsal oblique, volar oblique. How do you go that? It's a transverse amputation. Do the VY-plasty, mobilize it and cover it, and you can see 1 year down the line result. Again, thanks to WhatsApp, I can get all the follow-up just by making a phone call. Volar oblique. You can do a cross finger, you can do a thinner flap. These are the amputations parts which is showing. Why I prefer thinner flap? It matches the color. It matches the color. Young patient, no problem of stiffness. So you do it, the thickness of the skin is same, the color is same. So the only thing is you have to keep this finger for about 17-18 days and see the color matching of the fingertip. Cross finger flap, yes, it is one of the option. Dr. Agrawal has very nicely elaborated it. I am not going into detail of that. Is there any other option for this type of injury? If you see that the lot of nail bed is remaining over here, but if you debride that, the nail will be very small looking. The part of the nail, see, you can see that lot of the nail sterile matrix has been lost. You see the amputated part over here. What you do is, it's only this part of the nail is remaining there. So once you thoroughly debride it, and I covered with the sagmular flap. One side cutler flap, one side sagmular flap. A big VY on the lateral aspect, covering up to the PIP joint, here up to the DIP joint, and covered it. And then I created an illusion. I excised 2 mm of the epinecral nail fold. From here, I have excised 2 mm of the epinecral nail fold so that the nail will look 2 mm longer. It's just an illusion. No change in the length, nothing in the length, just epinecral fold has been excised. And if you see the follow-up, this is what I have achieved. You see the long mark of the sagmular flap, and this is what the size of the nail I got. Again, dorsal oblique, best treated by VY-plasty. Other option, if somebody is really super microsurgeon, like Jim So Kim of Korea can do a replantation of the fingertip. Even he can put the free flap on the fingertip from taking, I have seen him. Personally, I have seen him doing it. Homodigital island flap, toe pulp transfer, composite tissue grafting. What is composite tissue grafting? Especially in the children, around 50-50 chances. Have a small portion, clean cut, just put it back and wait. Immobilize, put it back and wait. You can, this is a book picture. And this is one of my patients. Unfortunately, I don't have the follow-up picture, but believe me, it's not platform to say something, not prove anything, but believe me, this patient is a normal finger. This all tissue, including bone, everything has been taken care just by the putting a composite tissue graft and the plaster. Replantation is not possible for me at this level. Plus 11 o'clock in the night. Patient wants something to be done. Revision amputation? No. There are one technique which is called as a graft reposition over a flap. What you do is, you take out the complete nail bed, denude the nail bed from the bone. You take out the bone completely, you shell the bone completely out. You fix the bone to the recipient stem. So now there is a distal phalanx with amputated portion. The amputated portion's bone has been taken out and fixed with the proximal portion. And the nail bed, including germinal and sterile matrix, has to be properly diligently elevated, separated, make a multiple small hole with 11 number line, suture it with the bone. You have to make some drill hole in the bone to suture the nail bed. Now the whole area should be covered with some flap, either thinner flap or cross finger flap. And this is what I did. Simple procedure. And this is from his form. He has sent me this picture with this finger, this nail he is achieving. So if you go back, we would have ended up into just a revision application. At this level, we ended up giving some nail of that size and that pulp to this patient. Some mentioning about the thumb injury because it's anatomically different. There is no loop end artery on the fingertip, like fingertip of the finger. There is no loop artery of the thumb tip. So when entire palmar surface of the distal phalanx of the thumb is avulsed with exposed bone and tendon, the cross finger flap or maybe FDMI can be a good choice. But when avulsion of the thumb fat is involved less than 50%, Moberg advancement flap is a choice. Here the almost full area is involved, cross finger flap and good function, but color matching is not there. When you have a 50% of the involvement, the flap is raised on both the neurovascular bundle, you flex the DIP joint little bit and close it, and you see 10-year follow-up. 10-year follow-up, again sent from his home by the WhatsApp. Just same more lesion, it's a fracture separation at the DIP joint from the epiphysis along with the nail bed dislocation. Whenever you see this child, this type of injury, don't forget to fix the fracture and reduce into the anatomical position. This is one of the patient, and this is what this is started with this and surprisingly presented about 7 days after the injury, and again reposition of the nail bed, pull out suture, and this is how things went. Thank you very much.